Good afternoon. On behalf of the Sparkman Center, I would just like to thank everyone for being here today. This presentation is Environmental Health Exposures for Women and Children in Suriname with Dr. Jeffrey Wickliffe, and it's our first seminar in our Global Health series this semester, so super exciting. Just to introduce myself briefly, I'm Cameron Durham. I serve as the Program Coordinator in the Sparkman Center. And before we get started today, just a few housekeeping things to go over. So for today's session, we will be recording today's session, and I'm going to go ahead now and start the record, which it's going. So just be aware of that, and then afterwards this recording will be posted to the Sparkman Center YouTube page. The session is a webinar format, so please utilize the Q&A option at the bottom of your screen to ask questions. We're going to save about 10 minutes at the end for Q&A, but you can type your questions in at any time. And then please also notice that closed captions are available and can be turned on by clicking the button on the bottom of your screen. So introducing our speaker today, we have Dr. Jeffrey Wickliffe. He serves as the chairperson and professor in the Department of Environmental Health Sciences here at the UAB School of Public Health. He also works as a senior scientist in multiple parts of the UAB School of Medicine, including the UWIRC Microbiome Center, the O'Neill Comprehensive Cancer Center, and the Integrative Center for Aging Research. Dr. Wickliffe has published research on multiple health topics, both domestically and internationally, surrounding maternal and child health in the presence of environmental health exposures. His intensive and impressive work includes, but is not limited to, oil spill exposure and birth outcomes among Southern Louisiana women at the time of the Gulf oil spill, the cumulative risk of prenatal exposures to chemical and non-chemical stressors on birth outcomes in Suriname, and a cross-sectional survey of pregnant women and arsenic concentrations of household drinking water in Peru. He also conducted experimental animal research examining genetic impacts of environmental radiation exposure at Chernobyl, Ukraine. And lastly, just want to say thank you to the Office of Public Health Practice, who is co-hosting this event with us today. Attendees, if at any point you have any technical difficulties, please feel free to send myself or Katie Adams, who's also on the call, a message in the chat. So with all of that, Dr. Wickliffe, again, thank you for being here today, and I'm going to turn it over to you.
All right, thank you, Cameron. Hopefully we are in presentation mode now. Good deal. All right, well, thank you again. Glad to be here. I didn't realize this was the first one, but that's pretty cool. Yeah, so today what I'm going to talk to you about is some of the research we're doing in Suriname in South America. And we're looking at what I would call a fairly complicated exposure matrix and mixture to a variety of heavy metals. And we're even looking at some essential elements as our interest in the dietary interactions between environmental exposures grows. So I'll touch on that. And the focus has been primarily on maternal and child health, reproductive health in moms. The cohort consists of pregnant women who were enrolled at the time during their pregnancy and now their children. Talk a little bit more about that. And from a children's health perspective, we've primarily looked at neurodevelopmental health. Many of the compounds and the elements we're looking at are thought to be pretty potent neurotoxicants. So we're particularly worried about neurological impacts in the kids. And as the study has matured, and I wouldn't say it's terribly matured, but as we've progressed through this, we've really started thinking more about how these exposures, which are being measured in pregnant women, adult pregnant women, as a proxy for exposure to the child during gestation, really kind of give us the sense that these exposures are occurring throughout the life course and across the lifespan. So we're growing more concerned about health impacts that span the life course. So I won't get into too much of that, but bear that in mind. All right, a little intro. I'll give you some information on Suriname itself. Most of the time when I tell people that I'm doing research in Suriname, they automatically assume it's somewhere over in Southeast Asia or Indonesia, but it's actually in northern South America, if you don't know that already. It's considered an upper middle income country by the World Bank. I think those are pretty lax standards they use, knowing what the economic challenges are there in Suriname. It's a former Dutch colony, so most everyone there speaks Dutch. Virtually everyone there also speaks English as a second language. And then there are a number of other languages that are spoken there among different groups. So what I'll go over today is sort of where Suriname is, sort of the characteristics of Suriname and some of the health characteristics, certainly of women and children. Give you the scope of the NIH Fogarty International Center funded research program that we have ongoing there now and that we hope to continue. Discuss some of the exposures that we've evaluated and assessed now, especially with respect to blood concentrations of heavy metals and some of the essential elements, and then some implications for health and some of the recent neurodevelopmental data that we've just gathered. So Suriname is pictured here. It's in an area called the Guyana Shield. The rainforest interior is considered Amazonian. So Guyana and French Guyana border Suriname, Guyana to the west, French Guyana to the east. Suriname is the smallest country in South America. French Guyana is not a country. It is still a territory of France. And then they're all bordered on the south by the very large country of Brazil. It's about 164,000 square kilometers. Most of the population, somewhere around 2/3, lives in the capital region, which is up here on the coastal plain of the country. And then there's a very large interior region that is mostly pristine rainforest, but I'll talk some more about what's going on in that area now and some of the growing development. But about 80% of the country is really considered mostly pristine rainforest still to this day. That's the very largest district, and about 7% of the population lives there, and they're quite spread out. Very small communities in the interior. For a small country, it's ethnically and racially pretty diverse. There's about 600,000 people there. The largest ethnic groups by way of self-identification are Hindustani. These are people of Indian origin. Tribal peoples, which are people of African origin. Creole, which is a self-identified mix. There's also a reasonable proportion of individuals who are Javanese, from Java. These waves of different ethnic groups correspond to different waves involved in primarily sugar plantation work, though there is no sugar production coming out of Suriname anymore. And then there's about 4% of the population identifies as indigenous. So these are people that have been there for millennia. And then you can see the rest. A very small proportion of individuals are identified as white or Caucasian. Median age is about 30 years. Life expectancy is somewhat lower than it is here in the US, about 75, 76 years for women, about 71 for men. The mortality rates are fairly high, so the lifetime maternal mortality risk is somewhere around 1 out of 330, so it's about 10 times the rate that you find in the US. Infant mortality per 1,000 is about 16 compared to 6 in the US, so a fairly high infant mortality rate compared to the US. Some other demographics, you can see sort of the demographic scale here on the right, the graph data showing the demographic proportions as you move up with age. The fertility rate's still pretty high, still above replacement, even though the country is shrinking to some degree. There is no migration into the country at all. In fact, there's net immigration out of the country, with most people either traveling to the Netherlands or other countries, including the US. The median age at first birth is similar to what we find in the US. about 27 years old. The adolescent birth rate is actually quite high compared to what you find in the US, 54 out of 1,000 versus 17 out of 1,000. Median birth weight's about 3,000 grams, but the percent low birth weight is pretty high, especially compared to US standards. So sort of maternal and child, just reproductive and birth outcomes are still a problem in Suriname. Not that they're not a problem here in the US, but they're definitely more of a problem in Suriname. If you look at the less than 5-year-old mortality rate, it's pretty high, about 18 out of 1,000 compared to 6 out of 1,000 in the US. And the preterm birth percentage is higher than what you find in the US. In terms of economics, the country formerly concentrated primarily on mining bauxite for aluminum. That was their major mineral resource and the major staple of their economy for many years. Aluminum is largely non-existent now, aluminum mining in Suriname. The remains of those activities are still there. They've just sort of been abandoned. So you see these massive open mining pits and all the old equipment that was used. It's all still there, but they no longer mine bauxite for aluminum. They've shifted more now to petroleum. They have a state-owned oil company, Staatsolie. And recently there have been some massive deposits that have been discovered offshore from Suriname and Guyana. And even though we all know we should be moving away from petroleum and fossil fuels, the very large oil companies, I don't need to name any name, but you can probably guess who they are all making their way to the coastal region of that area to start extracting oil. They also have a fairly large gold mining enterprise. There are some large companies that are in the mining operations there. One based out of the US in Colorado, another one based out of Canada. But they also have a very active artisanal or small scale gold mining operation. Much of that is illegal. And in most of those operations, they are using the very old method of mercury amalgamation to pull the gold out of the slurries. And then it's a dirty process from there on that I'm not going to get into, but it's something we are definitely worried about, especially from an occupational standpoint as an exposure to mercury. But in that process, obviously, they're losing a lot of mercury to the surrounding environments. And then it gets into the biological systems and primarily fish. Fish tend to be the primary protein source for most of the interior communities. And we have found that fish in those areas have fairly high levels of mercury. And I'll talk some more about the mercury in the individuals in those communities as well. They also have a fairly large marine fish and shrimp enterprise, mostly for in-country consumption, but they do export that as well. And then their other major agricultural products are bananas and rice. And there's a lot of pesticide use. I won't talk much about pesticides, but it's another group of chemicals that we are examining in terms of exposure to potential neurotoxicants. And those are heavily used in the banana and rice industry. And some of those are actually metals based, and I'll touch on that a little bit later. And unfortunately, there is a growing timber industry. Most of it's illegal right now. And so even though the rainforest is still considered largely pristine, you can now, even by way of satellite photos, start to see where there's some timber harvesting in certain areas. And you can also see the gold mining activities as well. So a little bit about the study itself. The study is called the Caribbean Consortium for Research in Environmental and Occupational Health, or CREO. I didn't come up with that, so if you love it, don't give me credit. If you don't like it, then it's not really all my fault either. But beyond that, this study was funded by the National Institutes of Health. The primary funder was Fogarty International Center through one of their programs called GeoHealth. The GEO, the E and the O stand for environmental and occupation. So that's why we have environmental and occupational health in our particular study, even though aspects of occupational health have not been a principal focus to date, that we are proposing to do more around occupational health as we move forward. All that to say, it's also co-funded by the National Institutes of Environmental Health Sciences, which is one reason why we're focusing on environmental health exposures. And then a couple of the other institutes and centers are providing some additional funding. It's a longitudinal environmental epidemiological cohort study. We've got now around 1,200 pregnant women enrolled in the study. The intent was to sort of over-enroll, knowing that as we carry this cohort forward, we would probably be losing people to follow up all along the way. And we really want to monitor the neurological health and neurodevelopmental health of these children, at least into their adolescent years. We hypothesized there would be distinct regional differences in exposure. We know that most of the gold mining is going on in the interior regions where they're using mercury. So for example, we hypothesized that we would find higher levels of exposure to mercury in interior communities and populations when we compare them to two of the coastal areas we're looking at, Paramaribo, the capital in the coastal region. Nakiri is one of the larger cities, though small by most of our standards, in the far northwest region of Suriname, which is where all of the real heavy intensive agricultural work is going on. The rice and the banana plantations are mostly centered in that region and in the coastal plain. Not much agricultural activity at all in the interior. So we assumed pesticide exposures might be a little higher in the populations around Nakiri. And I won't get too much into pesticides, but I will talk about a couple of the metals that are associated with those. Primarily, we were interested and concerned about environmental exposures. They really haven't been characterized in Suriname and some of the other small South American countries well at all. So this was really the first large-scale study that we were aware of in Suriname, looking at environmental health and potential impacts on maternal and child health. So we were focused on birth outcomes and reproductive health in our moms and children's neurodevelopment using a number of different tests and screening tools. The two that I'll talk about today are the Bailey scale of infant and toddler development and the modified checklist for autism in toddlers. The CBCL, Child Behavior Checklist, and Child Development Review data are in the process of being analyzed now, so I won't talk about those, but we have some emerging data with the BSID3 and the MCAT RF that I want to share with you towards the end. Just to give you a little idea of what these two tools are used for, the Bailey scales are really designed to look across a number of neurological domains in young children. This test we administered at 12 months of age. It's suited for that age group. And it looks at a variety of neurological domains, including cognitive domains, language, motor, fine and gross motor, and then scales that examine things like social and emotional functioning and communicating. The newest version, which is version 4, also includes some additional questions that get at adaptive behavior as well. The MCHAT is the modified checklist for autism in toddlers, and it's really focused on evaluating individuals from 16 to 30 months of age or so is when the MCHAT was, that's the age range the MCHAT was designed for. And it's really designed to screen for those types of issues related to autism spectrum disorder. ASD prevalence in the US is about 1 to 2 out of 88. So, it's not, extremely common, but it's a fairly common neurological problem in children. It's designed to screen for impairment in social interactions and communication, which is sort of a hallmark feature of those that are on the spectrum, whether they're high functioning or low functioning. They tend to have notable impairment in terms of being able to interact socially and communicate socially. And then often, across the spectrum, you find evidence or some indication that there are certain behavioral things that seem to be repetitive and definitely restricted. And so their interests are often quite limited as well. And then the MCHAT can also pick up on some other developmental delays. So we were concerned about exposure to pesticides, which I won't get into much right now, but there were two elements that are key ingredients, if you will, in some of the most widely used pesticides. One is a fungicide that's manganese based, that's used primarily in banana plantations, but also in the rice production fields. And then another pesticide, which is designed to get rid of snails and things like that, that's tin based, that's primarily used and most heavily used in the rice production fields. Snails are a real problem in rice production, so it's used to kill snails. But we were concerned that individuals living in and around those areas might actually be exposed to these pesticides either through consumption of these food items or perhaps drift as these pesticides are applied. And the other metals we were particularly worried about were mercury, because we knew it was being used pretty heavily in the gold mining industry. We're also worried about lead, because lead is a very well-known neurotoxicant. So we felt like it was important to include it, not really knowing that we would find lead exposures to be quite the concern that they are, but I'll show you that data in a minute. There's a common practice of consuming different kinds of clays and soils in Suriname. It's not uncommon the world over. The material is colloquially known as pimba. If you've ever heard of kaolin clay or anything like that, there's some evidence that some of those areas where people are getting that soil and that clay material are pretty high in heavy metals, including cadmium. So we were concerned that that might be another thing individuals were exposed to. And then two essential elements that we were particularly interested in were selenium and manganese. Manganese at high concentrations is a neurotoxicant, and there's some evidence that it affects neurodevelopment in children when the concentrations are high. What high means is still subject to debate. And then selenium we were interested in because of its antagonistic relationship with mercury. And what you find is at least what the literature is starting to suggest, is that individuals that are selenium insufficient but have high levels of exposure to mercury tend to be much more sensitive than individuals who are selenium sufficient, who are also exposed to higher levels of mercury. So we wanted to see what that looked like, as well as a possible dietary essential element that might actually mitigate some of the toxicity. We have more sites than this now, but these are the sites that comprise the data I'm talking about today. So again, we have two of these areas that are along the coastal plain where most of the population lives. And then we have kind of a transect of populations that runs from east to west and north to south. The areas that are 3 and 6 here, Brokopondo and the upper Suriname River area are where a lot of the active small-scale gold mining is going on. It's mostly in the east and southeast part of the country, very little of it in the deeper south part, and to our knowledge, really none in the southwest part of the country. So Tepo, for example, would be moving into an area where you don't really find any active gold mining, though we know the fish in those areas are contaminated with mercury. So it's either a product of older gold mining, but we think it's probably more likely, because it seems to be recent, it's probably just coming out of the gold mining areas and being atmospherically deposited downwind. That's the prevailing wind direction, goes from the northeast to the southwest. So we took whole blood samples. They were collected in trace element vacuutators that are designed for this kind of work. We took samples from our pregnant women late in the first, early in the second trimester, and then we took another sample in the third trimester. I'm only talking about those in the first trimester. We have looked at some data across gestation for those women that we've analyzed both blood samples for, and we find that the levels of these metals don't seem to change much over the course of pregnancy, which suggests to us that pregnancy itself is probably not having any dramatic impact on them, and that the exposures are probably fairly constant and continuous over gestation. We analyzed the blood for mercury, lead, cadmium, manganese, tin, and selenium. There's a little practice for your periodic table there if you don't remember all the two-letter abbreviations for elements. Our limits of detection were exceedingly low. We had no non-detects in any of our participants because our limits of detection were so low. The analytical chemists that do this kind of work now have really developed some fantastic methods. So we're able to quantify down to very low levels, parts per trillion in these individuals. Most of the data is not normally distributed, so we used a number of non-parametric methods along with some transformations, so we could use some parametric methods. I won't get into all of that. If you want to know more, glad to discuss it with you, but I'm not going to cover all that today. Now the data. So this is the meat of the study. So what we have here are the blood elemental concentrations by region, a region here in the far left. So Paramaribo is the capital, that's on the coastal plain, distant from the interior. Nicaria is in the northwest, again, along the coast, and in the Savannah region where they grow a lot of bananas and rice. And then the interior, we have sample sizes in here as well. And the interior, those communities and villages, which tend to be much smaller in terms of just total number of people living there, but they all have sort of similar characteristics in terms of what kind of practices are going on there. Very little agriculture. They don't have roads, so there's no vehicular traffic, nothing like that. You have to get to these communities mostly by boat or by plane, and then you walk in. I also included information from the latest NHANES report. These are median concentrations, and then in parentheses, I either have the interquartile range, or for the NHANES data, I have the 95th percentile. The cells that are color-coded, those in yellow and orange, those represent values and concentrations that were significantly different than those in the corresponding other areas for each one of these elements. So for example, you can see the mercury concentration in the interior is much higher than what we find in the capital and in the other coastal city. You can see in comparison, they're all much higher really than what you find in the US. These are all pretty heavy fish consuming populations. Fish are very popular, whether they're marine in origin or whether they're freshwater. So the communities in the interior eat almost exclusively freshwater fish that's locally harvested, whereas folks along the coastal plain tend to eat the marine fish that are harvested out of the South Caribbean / Western Atlantic Ocean. Lead concentrations were not a complete surprise, but the high levels of blood lead concentrations were actually somewhat surprising. The CDC has now revised the blood lead reference value down from 5 micrograms per deciliter to 3.5. So you can see that most of the population in the interior exceeds what the US CDC considers to be, at least at present, a safe threshold. If you look at the blood lead values compared to those in the US, the ones outside of the interior, the ones along the coast, are much lower, but still somewhat higher than what you find in the US. And the sources are something we're actively working on, using some really kind of novel lead stable isotope data and lead, but I won't report that here. Maybe next year I can come back and talk about that, so I can talk more about where all this lead is coming from, because it's certainly not the traditional sources that we think about in the US. Manganese was higher in Nicaria, as was tin, which is sort of consistent with the pesticide use and the fact that they use the manganese and the tin-based pesticides there. So this is hinting that that may be the source of exposure. And then we found that selenium concentrations were highest in the interior. And I won't talk about that too much today, other than mentioning the probable source, followed by Nicaria, and then selenium concentrations in the capital. Real quick, I just want to I don't want to spend a lot of time or have you drill down into a lot of detail on the two tables that I'll show you here next, but just to give you an idea that when it comes to mercury exposures, we dichotomized on what's considered to be the threshold for action. Those in the interior definitely experience the highest exposures, tend to be older women that have the higher concentrations as well. That's not unexpected. Mercury tends to kind of accumulate as we age. The ethnic groups that are most impacted are the indigenous and the tribal peoples, and they comprise the largest proportion of those populations in the community, along with some of the Javanese. So that's not uncommon. The other disturbing thing is that those with the least amount of education and those with the least amount of household annual income are also the ones that tend to be affected. So it's definitely a disparity issue and a vulnerability issue that is going to have to be addressed. The same holds for lead. This is lead levels dichotomized on the old action level, in the process of updating that information with the new blood lead reference value. But again, those in the interior, the indigenous and the tribal peoples, lower educated, lower income, tend to be the ones most impacted. I wanted to also explore with a very small sample size if the blood mercury, the blood lead, the blood selenium, if there was any difference between any of the self-reported groups. So we focused on the indigenous peoples, the tribal peoples, and those that said they were of mixed origin. And what we find is there really are no differences. So we were kind of exploring this to see if there were any cultural practices that might be a proxy for explaining differences in, say, lead. But we didn't find that, or we haven't found that yet. Again, it's pretty small numbers. Now to some of the neurodevelopmental data. This is just coming out now. This particular set of data is only looking at lead exposures and some other non-chemical stressors. We're looking at depression and perceived stress in the capital region where the lead exposures tend to be lower. So this doesn't even include the populations in the interior yet where the lead concentrate, the lead exposures and the blood lead concentrations are much higher. So it remains to be seen what kind of impact we're going to see there. And then I included the NHANES data here again, just for reference purposes. So what we did find was a gender effect, or a sex effect, I should say, in that boys tend to score lower on some of the domains. Usually they score lower on the cognitive domain. In this particular group of individuals, we didn't see that, but they also tend to score lower on the fine motor domain and the two language domains, receptive and expressive language. So this is pretty consistent with what other people have found when using the Bailey scales and looking at these different cognitive and functional domains, that boys tend to score lower than girls. So it gives us some idea that the test is probably being administered appropriately. We did have to go through some validation work so we could use this in Suriname, and this is all data based on the BSID work we did following the validation. We did also see an effect on cognition with mothers' perceived stress scores. This too has been seen in other studies, as well as effects of maternal depression on some of the domains. In this case, it was motor domains in the children. And again, other studies have found some similar findings. Of concern, and again, the blood lead values in these areas, while not as near as high as they are in the interior, they're still notable and still much higher than what you find in the US. And some of the children in this obviously have blood leads that exceed 3.5 micrograms per deciliter, which is that reference value. So what we did here is we dichotomized this. And what you'll notice immediately is the language domains, receptive and expressive language domains, receptive being, as you talk to the child, how do they react and respond to you speaking to them? Expressive is how do children express themselves through language. But in both cases, those with higher blood leads perform significantly worse than children with lower blood lead concentrations. The other thing I want you to notice across all of these scales is the fact that in every single domain, though not statistically significant, children with the high blood lead levels tend to perform less well or poorly in these domains compared with children that have lower blood lead levels. We also found, which is consistent with other studies, that education level and educational attainment in mothers has some influence on these domains, such that the higher you move up in terms of educational attainment, tertiary being college or graduate school or professional, as educational attainment goes up, you tend to see the scales and the scores on these various domains go up as well. And so that's another pattern that we tended to see in this data. And it was significant for three of the actual domains. Now for the MCAT, this data is from children that are kind of across the region. So this does include some children from the interior where the mercury exposures are highest. Again, I extracted that information from the table here so you can recall the blood mercury and the blood lead levels in these different areas in the mother's blood samples, but using that as a proxy for exposure during gestation, which seems to be plausible here. What we found was really no significant influence on the MCAT scores, and when we categorize them either low to moderate risk or high risk for ASD, no impact of lead. There is some indication that it's maybe trending that way, but at least the statistical testing did not find a significant difference. Now with mercury, what we did find was significant differences, such that those at higher risk and scoring poorly on the MCAT RF also tended to be those kids who had the highest mercury level exposures. And so there does seem to be the possibility that mercury, in this case, it's almost all methyl mercury because we've done that analysis, maybe having some influence on at least on the MCAT scores, which may suggest that it could be contributing to autism spectrum disorders. This particular form of organic mercury is different than that form of mercury that was implicated in vaccines many years ago, which was debunked. That was a form of mercury called ethyl mercury. This is methyl mercury. And while it may sound like there could be very little difference, toxicologically, it can oftentimes take very little for something to go from fairly non-toxic to toxic. We didn't find any influence with preterm birth or low birth weight. We didn't find any influence on sex, which was a little surprising because ASD tends to be much more common in males than it does in females. But again, this is a screening test, so it tends to be very conservative. Not a diagnostic test. And then we didn't find anything with education or BMI either. So I'm wrapping up now. To our knowledge, it's really the first study examining these complex exposures in pregnant women in Suriname. And I would say that research is really moving more into this space, whether it's in Suriname or whether it's in the US. And rather than looking at single agents as the potential driver of effect, we are more and more looking at mixtures and complex mixtures, including essential elements, but also oftentimes some of the social determinants of health. So our studies are getting more complicated and more complex, and as such need to be larger and larger all the time. So we feel like this is for the size of Suriname, this is a fairly large cohort study for a country where there's 500,000 people. The neurotoxic metal exposures are highest in the interior. There's a number of other socio-demographic factors that are also associated with those exposures that will need to be addressed. Sourcing these exposures, certainly to mercury and lead, is ongoing. Again, we're using some really novel, stable isotopic chemistry methods to try to source where the mercury is coming from, that we have a pretty good idea that it's coming from the gold mining, but just sort of providing that more objective proof to say, this is why this needs to stop. I would say the same thing goes for lead, so we can develop some sort of intervention, because at this point, we don't really know where that exposure is coming from. I would also say that the exposures to mercury, lead, are notably higher than they are in the US overall. We hope to continue monitoring and evaluating neurodevelopment in the children as they age, and clearly designing and developing some interventions and evaluating those around mitigating these exposures is important. The role that selenium might play in this as an essential element that might mitigate some of the neurotoxicity that mercury may cause, maybe, I wouldn't say it's off the table. We know that the inputs to the environment need to stop, but elements take a long time to move out of certain kind of biological and ecological systems. So even if they stopped using mercury today, it's very likely there will be substantial mercury problems for the next 10 to 20 years without any additional input from any source. So it's going to be something we have to deal with for some time to come. And I would say the last thing that I'd really like to see us be able to move forward into is looking at the interactions between some of these neurotoxicants, some of the heavy metals, the non-essential metals, some of the other chemicals we're looking at, especially pesticides, and then some of the dietary factors that we hope to continue measuring, and some of those that we're actually adding to some of the grant applications as we move forward that might also exacerbate the health effects, but in certain situations may actually counteract those. Just to acknowledge our funding sources, thanks to the Fogarty International Center. They need to have more money put in their budget so they can support this kind of research. What we learn in Suriname has direct application to what we can learn here in the US. There are certain communities and populations in the US that have much higher levels of exposure than what NHANES shows, because NHANES is sort of an average representation of the US. At least that's what the one of the intentions is. Takes an army. So I've listed several people here that have been instrumental in us carrying out and continuing this work. Folks in Suriname and folks here in the US. You can see some of the institutions that have been involved, all the way from the academic hospital in Paramaribo and the primary medical mission, which really is the only group that provides medical care to those in the interior, really focused on primary health care, and really shorthanded when it comes to any type of specialty care like neurological health, neurodevelopmental health. So we are working to try to build capacity there, and then some of the other organizations that have helped, some of the universities. And I think with that, I am through. And I'm going to stop the share, if that's okay, Cameron, so we can populate the.
Perfect. Thank you so much.
Yes.
So we do have some questions. One that came through that you kind of touched on just at the end there, but any implications or lessons that can be applied to more of a local context, either in Alabama or Southern United States?
Yeah, I would say so. We did some work, and Cameron mentioned some of the oil spill work we did, but one of the things we did look at, knowing that a lot of the folks that live in Southeast Louisiana and along Gulf coastal areas tend to be very heavy seafood consumers. So you do tend to find higher levels of mercury in those individuals. They actually, in comparison, they look a lot like the coastal areas in Suriname. The blood mercury concentrations are very similar in the population we looked at in Southeast Louisiana. Now, the flip side of that, there's a lot of benefits to eating fish too. And so I think it's certain, everybody hears the term methyl mercury and it automatically sort of invokes this fear of neurological damage and nerve damage. Fair enough. But the healthy benefits of consuming fish are so important. We've looked in Suriname, for example, at not only mercury in the fish, but selenium and dietary fatty acids, especially omega-3s. And not surprisingly, the freshwater fish are excellent sources of both of those. And there's emerging evidence that they can counteract or perhaps prevent some of the negative impacts that mercury may have. I would also say that if you look in Alabama, we have a lot of folks in rural areas. We have a lot of folks that live along various rivers. And a lot of those folks, I don't want to go so far as to say they subsist on fish like some of the communities in Suriname do, or some of the other communities in the US, but they eat a lot of fish. They catch a lot of local fish in those local rivers. And mercury contamination in some of those systems is a problem. And I'd like to see more work done in Alabama, especially in rural areas, focusing on people that actually do consume a lot of locally caught fish, just to see if what their exposures look like, and just to see if there's any possible effects on them or their family members who are eating these fish.
And when you're dealing with a coastal community like that, and the problem is in, like one of their main sources of food and nutrition, what do you do? Do you turn towards education or?
Yeah, I think that's exactly, you hit the nail on the head. You really got to take a deep look at it. So what are the exposures like? Just about any fish that you can look at is going to have some level of mercury in it. Now, the fish that you tend to worry about are the larger predatory species. If you look at marine fish, you're particularly worried about things like mackerel, things like, the large tuna, swordfish, sharks, things like that. In freshwater systems, you don't find anything quite that extreme in terms of size or mercury concentration, but then the predatory species that you find in freshwater systems also tend to be the ones higher in mercury. Now, looking at that, and also knowing that there's a lot of healthy benefits to eating fish, whether they're freshwater or marine fish, you really got to kind of temper your education with that in mind. What happens typically is you tell people there's mercury in these fish. Based on what we know in terms of risk assessment, you might want to advise certainly pregnant women to maybe not eat certain kinds of fish, or only eat them very rarely or occasionally. And what people tend to do is they go, well, he said that fish might not be good for me, so I'm just not going to eat fish. So I always worry about the fact that these advisories can have an unintended consequence of shifting people's diet away from something that may have a little mercury in it, but otherwise is probably very healthy, to something that may not be very healthy.
Yeah.
So it's a kind of a tightrope you got to walk.
Yeah. We had another question in the chat about regulations on pesticides and that sort of thing in Suriname versus in the United States.
So there are regulations on pesticide imports and what can come into the country. And they're fairly rigid. Suriname has, like many countries, banned a number of pesticides. It's some of the same ones the US has banned, some of the same ones Europe has banned. A lot of the organophosphates, most all of the organochlorines. The problem in Suriname, as opposed to the US, is they have very little capacity to evaluate the pesticides that are coming into the city, into the country. Sorry. So by that, I mean, they don't really have the analytical capacity to test pesticides to see if they are what they say they are on the label, and if not, what else are they? And then the one thing they don't address well is the fact that there may still be some legacy pesticide in the country that, whether it's banned or not, it's still there, and people are still using it. We did a very small pilot study on some produce that we obtained from a very large central market in Paramaribo, the capital, focusing on the kinds of vegetables and leafy greens that tend to be more preferred. And it was a very small pilot study, but we found in 2 of the samples of one of the leafy greens and one of the other vegetables, well, it's fruit, technically, tomato, 2 banned organochlorine pesticide residues, or 2 banned organochlorine pesticides showed up above the maximum residue level that's accepted in Europe. We were using European standards because Suriname tends to see itself as using those standards. But that just goes to show you that there's something going on. And even though there's policy, it's very difficult to enforce that policy very effectively. Same goes for policy pretty much over the entire country. They have very little analytical capacity.
One question that I'm not sure you'll be able to answer at this point, but what kind of are the next steps in an intervention? Or you mentioned that some of the data you found was more contingent on like cultural aspects or educational aspects or education within the mother. So going forward, like, you know, next steps, how do you identify those? And
Yeah, so I'll just use the mercury in the fish as an example in the interior. And you might recall that they tend to have the lowest education. And that's not to say that they're not smart people. They just have not gone to school as long as other people have and haven't really had access to educational materials the way, especially those in the capital have. There's been some effort by the Ministry of Health, which is their public health government agency, to provide or to, I guess, really provide advisories and advice on fish consumption in the interior. But my understanding is that was done one time. There was a simple poster that was developed that had the fish and the pictures and the recommendation that you don't eat, you know, piranha and a couple other the large predatory fish that you find that are actually preferred for consumption. But my understanding is it didn't work very well. And I think in part it's because people may not have a lot of options. In some of the communities, they're harvesting more bushmeat now. They call it bushmeat, with shotguns. And you know, one thing we have found out that they use shotguns and shot shells, and almost without exception, those shot shells are lead. So we have found that in some blood samples with the isotope, very limited isotope data we have, it looks like the lead in the blood looks very similar to the lead in the shot when it comes to isotope ratios. So that suggests that that's a source of that exposure. So, you know, you're telling communities who for generations, millennia, have relied on their local fish for food. And I just don't think it's been very effective. I think that's an area that needs major attention. I'm not the one to go out into the communities and tell them, you know, what I think. So, you know, I try to work through their structure and try to get information to them. I think most of them are well aware that the mercury is a problem and they're concerned about it, but they have just very little wherewithal to make any real changes. Mm-hmm. We did find in one community that's closer in, it's sort of in the central part of the country, you can't reach it by road. They actually switched to raising chickens. And so they're eating a lot more chicken as their primary protein source, and they've stopped eating near as much fish. And we have actually been tracking that community for about the last 12 years. And the mercury levels in both blood and hair have dropped dramatically in that community. So it's something that can be done. It's just, can the community find a way to take that advice in a meaningful way? Not easy.
We are just about out of time. If anyone has any last minute questions, please feel free to send them in the Q&A or to the chat. But thank you again so much for your time. I really enjoyed it. And again, this will be recorded and posted on the Sparkman Center YouTube for anyone that would like to rewatch or share.
Great. I appreciate it.
Yeah, thank you so much.
Thank you.
Bye, everyone. Have a good rest of your day.